Awesome.
Some of them are.
Okay, so we are recording. So once again, thank you all for joining us for the monthly journal club. I wanted to introduce Megan Doyle. So many of you know her, but she is a wonderful OT practitioner in the Treasure Valley, works for St. Luke's. She is our president-elect for IOTA and has done some wonderful work in the area of pain. So Megan, go ahead. Well, maybe first, before we segue into that, just really quick, for some new faces, maybe we should all go around and say who we are. I'm Brittany. I work at ISU in the OTA program.
I'm next to you on my screen. I don't know. Go ahead, Joanne.
Well, so I'm next to her on my screen. I was wondering how that worked.
Yeah.
I'm Joanne, and I'm the program coordinator of the OT assistant program at ISU. So welcome, MOT students.
Yeah. I'm Barbara Kornblum. My students know me. I'm the program director for the OTR program at ISU, and I've been doing pain management forever. I'm a certified pain educator. And my husband says that's because I'm a pain. So what can I say?
Maybe I'm Alexa. I'm an sorry. I was just gonna say I'm an MOT student. So
I'm Carly, and I'm also an MOT student.
Yeah, I'm Laura Lee. I'm an MOT student as well.
I'm Spencer. I'm also an MOT student.
Awesome. Thank you guys so much for coming. And then just a reminder too, before we get going, just for anyone that's watching the recordings, which that's what I'm going to remind us about, is I'm going to post these recordings on our YouTube page. So if you search ISU OTA, we have a YouTube page, and then that's where I've been posting the recordings of the journal club. So if you see that, I mean, certainly subscribe to the channel or share the postings, because obviously it's another great way for people to get access to these topics, and then hopefully build up our people that are making this a regular occurrence every month to get really good conversation in person as well. Okay, Megan, take it away. Give us a little bit more about who you are, what you do, and then feel free, go ahead and share.
Yeah, so absolutely. And it's so great to get this mix. I think this is so cool. Like my wheels were just turning, like, okay, like how I want to gear this conversation tonight, because I have those that are in academia, and then I have students. So I think we can talk on either side. And then obviously, those who have practiced in the field and now are teaching the next generation, and we have the next generation. So that could be a really great direction to go with some of the things that are in this position paper. I told Brittany, I actually really didn't want her to just read off a bio about me. It's really hard sometimes. I do put a lot in my bios, and I'm like, wow, that sounds like a lot. I graduated from Indiana University's OT program in 2012 and have an undergraduate degree in exercise science from Marquette University. And, the big thing for me, I've worked in a ton of different practice settings. My husband was active duty Army for 8 years. Idaho's the 6th state that I've lived in. This is our forever home now. We're not going anywhere now. He's National Guard now, full time. But what that's led is a career that I've done kind of a little bit of everything. And one of the things I knew was always there as an OT practitioner, one, first and foremost, practicing occupation-based, but I have a huge love for mental and behavioral health. And then always, didn't matter what practice setting I was in, didn't matter what clients or populations I was working with, there was always pain. Pain to me is probably one of the biggest issues our clients face. And it doesn't matter, pediatrics all the way up to the oldest of the old, doesn't matter what practice setting, what population, every one of our clients may experience pain. And so it was this big thing. And then I learned more about some additional training. So I have gone on, post-professional training, have completed a full fellowship in pain sciences, but I always caveat that, because what's so exciting about getting to talk about this position paper is that it's really geared towards every occupational therapy practitioner. So just because I've gone on to have all this additional training doesn't mean that OT practitioners shouldn't feel empowered just by our scope of practice. I mean, just by being OTs, to treat pain holistically and effectively using the things that we know to do. So, you know, the extra training did lead to me working on different opportunities and working with different, you know, interdisciplinary type things, and it's led to that passion. But I always want to make that really clear, and that's why it's so exciting to have students on tonight, because I want students to read this position paper and hopefully get really excited and be like, I didn't know that we could maybe do all this. And then it'd be interesting to have, you know, Barbara chime in, and Joanne and Brittany, not to put you guys on the spot, but if you start to look through the position paper, think, are we teaching our students this? And to make sure that's happening, because it's happening out in the field. So, you know, again, my goal for tonight is I don't have slides prepared. I have a few key points I kind of wanted to bring up, but I really want to keep things open-ended. You know, I would love to throw out some questions to the group. If you came here tonight, like a little skittish, although Barbara has her students, so of course, Barbara's going to expect you guys to speak up. You know, that's not my fault. So I want people to feel comfortable to unmic. You know, I wasn't necessarily planning on going into the details about how the position paper even came to be. But if that's a question, like even the students have, like, hey, what was the process for
I'd like
this
to know
happen?
that.
Oh, I can start there. Yeah, I'd be happy to start there. Yeah, so this was a total labor of love by the two key authors, who are Kimberly Bradeen and Nicole Rowe. Nicole Rowe being an occupational therapy assistant, by the way. I think that's so cool. So it was both an OTR and a COTA that teamed up together. They have written some continuing education pieces for AOTA in the past. They have a couple really great articles in past OT practice, but their passion just has always been pain and pain management. And they reached out to the powers that be at AOTA, the COPs, you know, the RI assembly, the groups that put these position papers together, and they said, hey, we're way overdue for this. Like, more research is coming out, more is being talked about, the Bio Psychosocial Model of pain. I think part of what helped too was in 2020, the International Association for the Study of Pain put out their newly revised definition of pain that's included in this position paper. So they had been really pushing for this for a while. And then finally, AOTA said, yes, you know what, you're right, it's time. The opioid crisis too. I mean, let's be honest, that definitely spurned this as well. And a lot of conversations about how OT needs to be included in any and all legislation that's related to the opioid crisis, treatment of pain from a conservative standpoint. And so they, in the early in 2020, reached out to me and the other authors that contributed case studies. So that was my role. I contributed Exhibit 3 case study. Kind of all came together, and they really wanted to make sure that we really presented a very broad scope of practice. You know, you have a pediatric case study in here. My case study is very much centered on polytrauma in an acute inpatient rehab setting. So like a new onset of acute pain. That's my passion, is treating acute pain holistically. You have a case study about complex regional pain syndrome that's treated via telehealth. So that was super cool, because we could really show, hey, you can treat CRPS via telehealth, guys. That's super cool. And then a couple other the cancer patient in hospice care. I think that case study is so great. And then a couple more, you know, an older male with spine surgery. And I think that there's one more in there. And then we also have an exhibit case study that briefly talks about how occupational therapy practitioners absolutely could do a group intervention for like a total joint group. You know, I think unfortunately other professions sometimes take that over, when OT has all the skills to lead those total joint groups, because we really go over it all. And that's what that case study talks about. It really talks about all those different facets. So we submitted our initial rough draft, I think it was like July or August of 2020. And then, you know, that took a whole editing process over a few months with AOTA. And then I think it was in the spring or so of last year, 2021, that it had to go before, you know, the RA, the assembly, to get approved. And there was a survey that was sent out to all AOTA members for them to read through the position paper, to provide any feedback or comments. And thankfully it went through completely unanimous, was voted unanimous for no additional changes, and got published at the end of this past year in AOTA. So it's certainly something that started out a long time ago, but it took a couple very passionate practitioners that were very big advocates and just were really passionate and putting this together. And again, it's really cool because all the case studies are taken off of very much real world clients. I'm happy to talk about that tonight too, because my case study that I did carry is definitely an amalgamation of two very specific, you know, obviously you couldn't tell who it was, but all the things that were detailed in my case study, I absolutely have done. You know, so I think that's really cool is it's all evidence-based. You know, you look through the case studies and you see with every intervention, there's at least one, if not two research articles that support that use. And just, it's all, you know, different things that we want different OT practitioners to feel like they can do. Is that a good synopsis, Barbara?
Yes.
Okay. I saw you trying to find the mute button. I was like, I think she's also shaking her head. Yes.
Yeah.
So I appreciate that. So yeah, I mean, that's the other thing I do want to share. It is really cool. I especially want the students to know, you guys to know, if you get into practice and you're really passionate about something, there's so many opportunities for contributing to things like this. You know, I'm a full-time working clinician that's just chosen to do these other opportunities and has made it work. And so it was really cool to have this opportunity.
Joanne, did you have your hand up?
I do. And Megan, I just, when you were going through your case studies, on all of them are relevant, but in the area that I noticed when I was working at the acute Jerry Psych Hospital in Twin Falls before I came to ISU with the dementia population, folks that are not able to verbalize that they are in pain. And we found that so many times the behaviors were because they were in pain. Pacing was actually a result of pain. And we didn't, you just don't think of it, you know, pacing, what they need to sit down, they, you know, whatever. And once and of course, I wasn't in tune to the practice at that point. I was just putting my detective hat on to figure out why they were doing the behaviors. And we did the pharmacological treatments of pain meds, but it'd be interesting to go back now if I had the opportunity and see what I could do non-pharmacological wise to treat, you know, other than we did, you know, work to get them to sit down, get off their feet, different, you know, ways like that. But I'm sure there are a plethora of interventions that could be done from an OT perspective to help those that can't communicate their pain to be relieved of it.
Mm-hmm. And so much of what we do is so, you know, is it like not invasive? You know, one time I was telling my rheumatologist, it hurts when I do this. He said, you're an OT. You should know not to do that. Do it a different way. That's what you do when you're an OT. And, you know, it's just so interesting that, you know, that's true. That's what we do. And so much of it is just seeing the world a different way. And, you know, why do you have to do 4 loads of laundry in one day? If it hurts, you could do 1 load one day and 1 day the day after. And, you know, so much of it is just the way we think. And the rest of the world doesn't think the way we do. So you don't have to operate on someone because it hurts when they do laundry. You could teach them to do laundry a different way.
Yeah, no, absolutely. And so and I do want to come back to Joanne. You know, this position paper wasn't like massively all encompassing. There's definitely a couple key things here though, that we can circle back around to with that, because that is a key point. And to Barbara's point, you know, we as OT practitioners learn help people and not just with pain, obviously, but ways to compensate and things like that. One of the things though, I think that this position paper really takes it a next step further is it really would say to that person that is trying to do 4 loads of laundry in a day, we know that occupations have value. I would be interested to know what would be some of the underlying reasons why that's so important to that person. You know, we know that there's different behaviors or patterns or things like that.
It's laundry day. You know, it's always been laundry day. And,
Yeah.
you know, just teaching someone that doesn't have, it could be laundry hour instead.
Yeah, there could be other things too. So,
Yeah.
you know, based on this, and again, kind of some of the areas I wanted to talk about, it's trying, you know, not even just to make that recommendation, and this paper gets into that, but recognizing first and foremost, when we're working with any clients, but especially somebody who's in pain, to try to acknowledge their lived experience and try to have a very much a collaborative attitude to help things work for them. So again, I wouldn't be surprised if that person that's doing the 4 loads of laundry, let's say they're married and they realize in a moment of clarity, well, part of the reason why I feel so obligated to do this all the time is because that's the way that I was raised and that's what my husband expects. And I feel like a complete failure if I don't do 4 loads of laundry every day. That's a really understandable and actually pretty significant psychosocial component. And one of the beautiful things that we know now is that we as OT practitioners, I've joked that we're like the biopsychosocial hipsters. I was like, we were doing biopsychosocial before it was cool. There's been this massive turnaround in the medical world of, oh, wow, we really shouldn't be just looking at this in a very rigid biomedical way. There's a person here with thoughts and feelings and a thinking brain and all these different aspects. And that's why OT practitioners, our scope of practice as OTs is so well suited to this. So some of the things that the position paper gets into is first and foremost, the very first statement that from AOTA, OT practitioners are distinctly prepared to work independently and to contribute to interprofessional teams in the treatment of pain. And I really wanted to highlight that because a lot of times I feel like we get kind of almost bred to think that we only function in interprofessional teams and settings, but there's actually so much here. And Linda Crawford, one of the contributing co-authors, she wrote the case study on the telehealth CRPS, Robin. She owns her own business that she's an OT entrepreneur just doing chronic pain. And she has a lived experience of chronic pain herself. And so that I think is so cool to point out that this really shows, hey, actually occupational therapy as a standalone, profession could also provide effective treatment for somebody. Obviously there's, the benefits of an interdisciplinary team, but I love that statement at the beginning and I really wanted to point that out. The position paper then goes into that new definition of the study of pain. And one of the parts that I wanted to point out, I'd be interested to get people's thoughts on, is it says the purpose of pain is to protect the person from actual, potential, or perceived harm. Does anyone have thoughts on that? Be curious to know what you guys think. Actual, potential, or perceived?
If I can just comment just on what I thought as I was reading this, it puts a bigger perspective on, well, you already mentioned it, but the Bio Psychosocial Model, which is not just the physical element that can be observed, but incorporates, there can be other types of pain that don't have to do with what you can observe happening with a person's body. It could be a pain of a relationship that is affecting an occupation or something, that's kind of an extraneous example, but things as radical as that cause people pain and affect their occupations. So yeah, I just thought it was a really interesting way of looking at pain.
Oh, I appreciate that, Spencer. And that's the whole point. And that's where, it's not just our profession. Other medical professions were still really far behind on incorporating these new definitions and the latest and greatest in understanding pain neurophysiology, and just really understanding that, it doesn't matter what type of pain it is. The way pain works, you cannot separate a physical from mental because neurophysiologically those things are interlinked. You can absolutely have pain produced without any, bio or like physical onset event, if you will. And that's what that whole perceived threat is getting at. Understanding that our pain is set up as this alarm system and this processing system where we can have an onset of pain in relationship to a significant emotional stressor, or again, a perceived threat. If the brain and body think that the body is in danger, it's going to produce pain. Another way to think about that, there's a cool little metaphor where I think all of us could imagine this. You know, if you're walking in the woods and all of a sudden you brushed your leg up against something and you don't know yet what it is, your sympathetic nervous system is going to go into overdrive for you. And you're going to think, oh my gosh, I just brushed my leg up against a snake. And then you look down and it's just a bush. And so that's you know, another way to think about this, where it's all about that threat perception, and it's all about that production of this, and it's interrelated that way. And then some new terms that are added in here. And I would just be interested if this is the first time anybody heard the term nociplastic pain. Has anyone heard that before? So that was a new definition that came out in 2017. Has anyone heard of central sensitization? Okay, Barbara's nodding her head. So Barbara's nociplastic, the IASP decided it really needed to take it further to explain what nociplastic is. Nociplastic pain can occur as a result of altered nociception. So nociception or nociceptors are from our periphery. They send all the lovely nerve signals to be processed through the spinal cord in the brain, without evidence of threatened or actual tissue damage or disruption to the somatosensory nervous system, meaning that there is no nerve lesion, meaning that there is no, I mean, it's the most lack of bio in this whole picture, if you will. Inadequately treated pain can result in adverse effects such as delays in healing, changes in the central nervous system or neuroplasticity, and even suicidal ideation behavior. So a great example of a type of pain that is now classified as nociplastic pain is true fibromyalgia. Because what has been found is that there is no nociception, there's nothing coming from the periphery like we would expect to then be processed and then produced as pain. This is where we can see, you know, for instance, someone with fibromyalgia may be able to know, wow, you know what, I was going through a really stressful time today, and then I had an increase in my symptoms. And so it's literally the central nervous system. So it's all central producing it out. There's nothing being interpreted from the outside. And it really gives a lot of legitimacy to, unfortunately, something that was thought of for so long as something that wasn't real. And that is another cool, I shouldn't say cool because stigma isn't cool, but you know, and again, that's actually where I would love Barbara's thought on this, is Barbara and her lived experience. A huge part of this position paper is recognizing that OT practitioners can really validate and support our clients that have been going through all these different medical conditions and pain, and that they do encounter stigma in the medical system. So if you have any thoughts on that, Barbara, I would love to have you share.
Yeah, I mean, a lot of, I mean, one of the reasons I got involved in pain management is because I have a very rare condition. I'm a kidney stone former. And I grew up and I would have back pain and complain to the doctor. My mother would say, don't listen to her. She just wants a Milwaukee brace like her friend Maxine. And for those of you who are too young to know what a Milwaukee brace is, it was a brace that had your head up like this. Nobody wanted a Milwaukee brace. And so, you know, I'm passing kidney stones and my mother thinks I want this. So I started to realize that I had to become an expert on pain so that I could, you know, explain this to people. Now there's 4 Facebook groups with it. Nobody's ever heard of it, but there's 4 Facebook groups. I've done research, studies asking people, you know, do you think this is a chronic pain condition? And overnight, 230 people answered yes. So, you know, it comes from my own experience. And so I kind of understand when people have pain and doctors and you know, don't buy it. At least therapists, we understand the lived experience. We know. I mean, somebody's not going to say, you know, I can't do this, I can't do that, I can't do this because of pain unless they can't do it. I mean, that's just the way life is. People want to be able to participate. That's what our profession is based on, is that everyone wants to be able to participate in their own lives to the fullest extent possible. So when pain interferes, you know, it's real. And that's part of why, I got into this. So having that ability to have some empathy and to start with people and say, what is it that you would like to be able to do that you can't do? Or what helps your pain? How can we, work something out that helps your pain? So it's really, to me, it's a matter of quality of life. And I think that quality of life is a real important piece of occupational therapy. And quality of life to me, my research, quality of life is not how many hours of sleep do you get? Do you eat 3 meals a day? Quality of life is, are you able to participate, can you participate in what you want to do? One of the studies, I'll never forget, this woman said, if I could just get down on the floor and play with my grandchildren, I'd have quality of life. So, that's where we're from. You may live with chronic pain, but how can we improve your life as OTs? How can we enable you to do what you want to be able to do and you need to be able to do? To me, that's what's really important.
No, that's beautiful. And so that's the other, and it's a perfect segue into the other big takeaways from this paper. So it is important for us to understand the neurophysiology, because all the research has shown that if we as healthcare practitioners in general, just not OTs, have that understanding and we can convey that understanding to our clients so that they better understand how pain works, that's super empowering, because then they're like, oh, wow, this is real. And now I understand, how my emotions play into this and my upbringing and just all these different things is very important that way. But then this paper, it really gets to the point of the actual lived experience and helping people engage, as Barbara just said, that's so beautiful, of if I could only just do this, or what are some of these occupations that I want to do. We as OT practitioners learn that when we are providing occupation-based treatments and interventions, it's always that interesting dynamic of the occupation is the goal, but it's also the treatment. And that fits directly in line with best practice for pain treatment, is if we are helping people engage in those occupations, find the things that they want to do. This position paper has all this wonderful research attached to it. Fisher et al. From 2007 is in here, did research on occupation-based treatment and participation in occupations itself, was a pain intervention, and people's pain intensities and numbers and reported pain interference went down. And then this is where I get super nerdy about this stuff, because I love the neurophysiology. But on the neurophysiology side, it really legitimizes what we do as a profession, because I just talked about how ultimately pain is all about threat perception. Pain is about protection. For those that go on to have persistent pain conditions, the pain has become its own disease process, in the sense that we now have an altered sensory response, and that is keeping that elevated sensory or nervous system response. And so when people are engaging in those occupations and they're like, I was so afraid of doing this, I was so afraid I was going to have more pain with this, and they're doing something they really enjoy, and they're like, well, why all of a sudden am I feeling better? They are literally feeling safer. They have less threat. Now they're doing something that feels really good. And that is the best pathway we know to someone or our own bodies providing our own natural painkillers, our own endorphins. It's been really beneficial. Again, we are not providers or prescribers, but we know in all OT programs, OT and COTA programs, we need to have at least a base knowledge of medication. It's really helpful to explain to someone, again, our role, and there's even a section in here on interventions. Our role is not to tell somebody if they should be taking medications or not. I always make that really clear. If people say, well, I'd love to learn ways to use less pain medications, I'm like, great, we can talk about that. But that's part of the stigma too. Our role is to support them in whatever is beneficial to them. And if pain medications are certainly part of the picture, then they are part of that picture. But at least being able to educate someone on, do you know why something like an opioid actually works in the first place? Well, it's because our bodies produce endogenous opioids. That's why we have receptors for them. And when you are doing something you really enjoy and you're in the moment, you're doing an occupation that you really enjoy and you feel really good, your body is giving you endorphins, you are feeling less stress, you know, and then if you're getting that benefit of the social participation piece, you're getting other hormones like dopamine and serotonin and oxytocin. All that to say that participating in occupation is something that is an intervention because it releases those natural painkillers. So does anybody have thoughts on that? I mean, that's hopefully one of my big takeaways from tonight is for you all to feel that much more confident, like, wow, when I help people do an occupation or do an activity they really, really want to do, and they're having pain, I am absolutely providing them an evidence-based treatment to help reduce that pain interference. So any thoughts on that from anybody? I just had to nerd out because it's so cool.
That's okay. If you're going to nerd out, I'll nerd out too. We've done a bunch of studies on what we came up with is the theory of occupational autonomy, which we're working on the publications. We presented it that occupational autonomy is the ability to do what you want to do when you want to do it, and it came up through the pain research that you know, even though somebody's in pain, they're going to want to. There's something they want to do, they'll do it, like, you know, playing with the grandchild on the floor, things like that. So I think that if we look at that as a goal, that everybody's got a goal, and that people will do things even if, you know, if it hurts, not necessarily, you know, stage 4 pain or however you want to measure it, but you know, that's, if it's important to someone, they'll do it. Our job is to help them do it without the pain. So, you know, that's where I see, and it might be as easy as teaching someone to, you know, not bend their back, but bend their knees, you know, to do it a different way. And I think that that's a really important piece for OT, that if something hurts, how can they do it if they want to do it, if they still need to do it, without it hurting? And that's, you know, our brains we're taught to problem solve and to figure things out and how to do things. And I think that that's where, you know, to me, that's one of the differences between OT and PT, is that we think that way, is how can you do it and maybe it hurts less, or how can you change the environment so you can do it and you're not bending that way. And I like to look at OT that way with pain patients.
No, fantastic. And actually, so on page 6 of the position statement, one of the things I highlighted was, most important, the practitioner should work to identify the client's goals for occupational performance and pain management. It is important for clients to understand that eliminating their pain may not be realistic, and that becoming an active participant in their own pain management may be the most beneficial strategy for achieving their personal goals, which includes increasing occupation performance. And that goes for acute and chronic pain. So that was something I was so passionate about, I was so happy about with this position statement, is that everything that's detailed in this position statement is really not to delineate, oh, here's what we do for chronic pain, oh, here's what we do for acute pain. You know, we know as pain becomes more chronic, there is definitely the research to back up that there are many more psychological and social factors. But you better believe, if all those things are going on around the onset of an acute pain state, how is that then going to influence that? So it's important to look at that big picture. You know, and so with treating and working with clients with chronic or persistent pain or even acute pain, helping them, like Barbara was saying, the language really should be more about, how do we help you do this despite? Not to say we want you suffering. There's a total difference there. We are not saying, oh my gosh, you know, you're laying here in agony, pain, and suffering. But how do we help you do despite, within a reasonable amount? And that's where that pacing aspect certainly comes in. And the graded exposure of doing a little bit more and a little bit more to where those levels are, you know, I don't not have any pain, but this is okay. This is tolerable. You know, I think for
sitting instead of standing.
Yeah, some of those different things.
Yeah.
Well, and this is also one of the, you know, and I hope I'm not jumping around too much, but on the next page, when we go into some of the intervention sections, we're talking about some different skills like self-regulation and self-management. So it really, in that self-regulation piece, and this is on page 7, talking about different regulation principles like sensory processing, which again, what's old becomes new again. It's like, hey, OTs have been doing sensory processing since the beginning. Glad you're all figuring that out now. Yeah, it's, oh man. That's why we got to keep advocating for ourselves. It's like, surprise, surprise, using the adult sensory profile in patients with chronic low back pain. You think that they're going to have different sensory profiles? Yes, yes, they do. So just incorporating that sensory processing piece, but with self-regulation, desensitization training, graded exposure. But there's such a cool study that's cited in here by Goodman et al. 2019, where they actually looked at the concept of occupational mindfulness, because that's a real thing. It's really cool. And some of the quotes of being mindful with pain, you know, really putting yourself, like if you're, it's kind of like being in a flow state, you know, if you can put yourself in the context of that activity you really enjoy, maybe obviously using some different techniques like deep breathing, biofeedback. You know, breath work has been found unequivocally to help with that response because it reduces that processing and it really helps reduce that threat perception and helps tap into more of the parasympathetic nervous system versus the fight or flight sympathetic nervous system. So, you know, working with a client who is very fearful maybe of taking a shower, for instance, after a surgery, and working with them on some breath work and just helping with that relaxation response when they're doing the shower. And you're doing that in the context of an actual, you know, occupation-based activity. You know, the other part of this document that is really highly emphasized, and again, really sets us apart from the other professions that address pain, is the emphasis on self-management. And that is, again, regardless of acute or chronic pain. Self-management gets talked a lot about in chronic conditions, but it's also super beneficial in acute pain. And I love, you know, so much, Barbara, when you talk about, you know, occupational autonomy, because it also just makes me think about the whole hallmark of self-management is, you know, what can I do for me? You know, what can I do for this? What am I in control of? And our clients need that control and that autonomy, regardless of this is a, you know, a brand spanking new pain condition, a new onset, or they have been having a lived pain experience for many years. So self-management is huge, and that's something that we do for every client, is focusing on that independence with self-management. The only other part in this earlier section I wanted to talk about, and I'm interested again, kind of from the students, or certainly those in academia, in the evaluation assessment section, what I love is that it talks about taking into account the impact of pain, but in addition to physical, cognitive, psychosocial, and sensory perceptual factors, the practitioner, you know, and it goes into some of the more traditional things like presence, intensity, location, type, and frequency of pain. But also when we're assessing a client or doing an initial evaluation, to be looking for, you know, what are their current pain coping skills? What are the skills they already have? What are their own personal perceptions of their pain experience? You know, what are their explanations for what's going on and why, you know, what's contributing to their pain? Their cognitive and emotional responses to their pain, and then also the concept of pain self-efficacy, which is, again, what can I do despite having this pain? So, and then again, that's the implication there, is to be incorporating that regardless of, you know, this is like a post-op patient, or again, this is somebody that you're seeing with chronic pain. A lot of this didn't just come from the Health and Human Services document from 2019. The International Association for the Study of Pain has curriculums for pain management in different health disciplines. And they have a really great one that's super detailed on the website, the IASP website, for occupational therapy. And they really state that all of these different components, you know, the general occupational therapist should feel comfortable assessing all of these psycho and social components of a person's pain experience, again, regardless of if it's an acute or chronic pain experience. So that was a lot, but just any thoughts on that? I would be interested to hear that, or certainly if any of the students feel like they want to to speak on that or anything so far, if this is kind of interesting, thinking about trying to assess your future clients and making sure you're looking at these aspects of their pain.
I had something I just wanted to share a little bit earlier when you were talking about like the pain science education and like helping patients understand like where their pain is coming from and why participating in these occupations is actually helpful. I feel like that's something we haven't addressed as much in classes. I feel like we talk a lot about, like pacing and conservation of energy and like ways to modify and do things differently. But I feel like something that I learned in a fieldwork as well is if the patient doesn't really understand how things are going to work or why they should do what you're recommending, then they're not really going to do it. And so I think it's an important piece to be able to understand the science behind it and then to be able to explain that to the clients as well. So I really like that. I appreciated you nerding out about that. That was helpful for me to understand it. So
well, I appreciate that, Alexa. And again, it's all of this is still the research is still coming out fast and furious. These newer models of pain have not been around for too long. Honestly, we're going on maybe the past 15 years. Especially again, nociplastic pain was only incorporated a few years ago. So it's just, because I never want to pin it on like one discipline or not. But I do believe it's our job to know that this is out there. And I'm hopeful that, for instance, for the occupational therapy profession and programs, that like, for instance, the AOTA standards to change and incorporate more updated models and things like that of pain neurophysiology. And the important thing there, Alexa, is that you don't have to get super nerdy about it when you're explaining it to them either. Kind of almost to Joanne's point way back earlier, I certainly have worked in a population. I work primarily in an inpatient subacute rehab setting right now. And trying to explain some of these concepts in a way when I know I'm working with somebody that really does have significant cognitive deficits, how do I help them understand? And at a bare minimum, I think helping them recognize the relationship between increased fear or anticipation and how that could impact that pain and the relationship there, that of anything else seems to make a really big difference. And again, just creating and cultivating safety. So I actually want to come back to that really quickly, Joanne, because I know that wasn't as contained as well in here, but that sensory piece. So it makes me think of, I'm going to mispronounce this, I think, Snozellen rooms. Yeah. The sensory regulatory piece here is what I think is the best thing that we could do for a population like that who is not able to maybe cognitively express. So instead of taking a top-down approach, meaning, right, like the higher level here approach, like we might do, to use more of a bottom-up. So to do the sensory pieces, the sensory regulatory, to do some co-regulation with that client who wouldn't be able to, unfortunately, maybe initiate deep breathing as a strategy on their own, but could you train caregivers to help do that and to recognize some of those signals?
And that's exactly the kind of things that we did without really knowing that's what we were doing, because again, that was my prior academic life. And I wish I could go back now that I've been in academics, because you learn so much more when you teach. But we would consider, hot baths or putting, getting them to telling them stories while we got them to put their feet up, foot rubs or back rubs, or getting them calmed down, and just a lot of sensory type approaches that were available to us at the time in a very, it was acute psych. So there was limitations on what we could do at the time. And I have been in the same administrator, also had a skilled nursing facility, and we had talked about building, I think it's Schnozzlem is the term, trying to build one. And it just, I've been around a couple of times trying to get facilities to do them. And there was one in Twin that did have one that I actually went and looked, and it is pretty cool. Just you paint it a dark black or dark navy blue or whatever. So it's a dark soothing, and lots of different types of comfortable bean bags and to sit in, comfortable couch, rocking chairs, aquariums with fish that are floating by, and the LED light filament lights that they could touch and move, and just lots of sensory experience to help take their mind off of the pain. Soothing, comforting, safety, all of that goes with, yeah.
And see, there is that distraction component, but now you know with the neurophysiology and the sensory regulation, it actually helped to alter the processing system itself. And so all these different things, this is what so intrigues me, is that a lot of these sensory regulation pieces in OT live in certain areas. Like they only live in peds, or they only live in, dementia. And there's a huge need for helping an adult be able to have a sensory diet. I've certainly treated adults where they were diagnosed younger with, AD, or well, actually that's not true. They weren't diagnosed with ADHD until adults, and went on to, again, there isn't a direct correlation, but there's really good research out there to show now there's a correlation between sensory dysregulation and the future onset of persistent pain cognitions. And it's because, or pain states. And it has to do with those pathways. It has to do with now you have this altered sensory processing, the altered nociception, and the way that system is regulated. Something else too that this document doesn't get into great detail, it briefly mentions things like socioeconomic status and social determinants of health. There's such a significant need for an understanding for all healthcare professionals to be very much trauma informed. That's turned into kind of a big buzzword. But again, there's a huge body of research to show there's a high correlation of children that go through and have a high level of adverse childhood experiences going on.
Are the big thing now.
Yeah. Great research to show, unfortunately, in addition to other comorbidities, but chronic pain is very much interrelated. And if we now better understand the neurophysiology, again, if we come back to this overarching principle of safety and threat, it is literally that child's nervous system developing in an environment that is making them think, I need to protect you at all times. Whether that is, living in a very chaotic home, moving around a lot, unfortunately, sexual assault and abuse, emotional abuse, physical violence, all those things. And so a way to talk about some of these concepts to clients if they come up to is always to validate. And this is where understanding the neurophysiology can be so helpful, because you're really validating and basically saying, in the same way we would working on sensory processing, this is not about right or wrong. This is the way your system felt it needed to keep you safe. And there was a time and a place for that, but we can help you retrain that in a way where you can learn some skills and we can make sure you can engage in those occupations. So the trauma piece here is super huge. I've worked with so many persistent pain clients where anecdotally, but the research is there more often than not, there were many adverse childhood experiences. And that's just a really, but we can really empower our clients with the understanding that this is all about neuroplasticity, and therefore it doesn't have to stay that way. That is not to say that the pain intensity on the numerical pain scale may go down to 0, but that they can find ways to engage in occupations, feel safe, participate, really get that enjoyment out of life, and that can really reduce that pain interference. And there are stories upon stories of people where they really felt like the years that they had of their persistent pain, they really don't experience that the way that they did anymore. It certainly isn't interfering with their quality of life. So I'm looking at the clock. I know it's 7:24. And if we, oh, sorry, go ahead, Brittany.
I was just gonna say, I saw Laura Lee's hand up a little bit ago, so I didn't know if you had something you wanted to add still.
Oh, not too much. I was actually just gonna kind of go off what Joanne said, because I did a presentation for an intervention last semester on the Schnauzelen rooms, and that was one of the things that I found is so many facilities weren't able to actually ever convince anyone to put it in fully because it just was that cost. And then there were so many studies that they were more qualitative, and sometimes it was hard because they couldn't see like the benefits for a huge population of clients because the change was either like so drastic or it was relied upon like the individual reporting. But I still think they're like very critical because I've worked with a couple residents who are on a lower cognitive level who had a brain injury, and when their sensory system was overloaded, their pain levels definitely increased, and you could tell because they responded with adverse behavior.
Yeah, no, absolutely. So again, like this is where we have all this training and we can apply it here, you know, to have that understanding of how we can help our clients with that and help with those. Again, kind of this, you know, top down is more, you know, where interventions like the pacing or different things come from. Cognitive behavioral therapy, acceptance commitment therapy is a bit more top down, but there's very, very much a place for bottom up. So that is the sensory regulation, that is the breathing, that is the mobility, that is these kind of more body interventions that then we know also influence, you know, ultimately the cognitive processing of pain. So OT practitioners are really well adapted. Thank you, Barbara, so much. OT practitioners, we really have it all. I mean, that's what this document gets into, is that pain really demands both these top down and bottom up approaches. OTs do a really good job of doing the top down, but bottom up also has a role. You know, my other hope too is you guys reading this position paper, and I myself fell into this trap. You know, I worked a lot in outpatient when I was in my career, and I almost felt like for a while, the only way I was going to be successful in pain management or pain treatment was to act more like not my discipline. You know, I sought out more manual therapy courses and things like that and felt a lot of pressure. And so coming around and really recognizing the value of what we do as OT practitioners, and the heart of that is occupation, and really addressing the biopsychosocial together, the mental and behavioral health. This document's really, I think, is a call to action of don't try to be another profession in the treatment of pain. Be our profession, because our profession actually is what the treatment of pain really demands from this big picture perspective. So if there's any questions, I know I really didn't get to go into the case studies. I was kind of worried that was going to be a little cumbersome. You know, I'm happy to have people ask questions real quick about those, or certainly I'm happy to share, you know, I can throw my email in the chat if people want it, and you guys can reach out to me if you have questions.
Yeah, and hopefully you MOT students should have had access. So let me know too if anyone didn't get the position paper, or for future reference for journal clubs, people can certainly email me and I can pass on the information for the articles. Megan, I wanted to say, I mean, this is totally maybe this is now in my other professional world. It's interesting, because I've heard you talk about pain in the past, and it's kind of sparked my interest with like athletic performance and tolerating pain, you know, that I'm inducing, along with like pain and injuries. You know, just with ultra running, I have a lot of chronic pain, and I you know, the whole application of neurons that fire together, wire together, and my perception of, you know, fear of an injury or fear of repeated injury, you know, that, I mean, that's totally applicable obviously in just general pathology, but interesting in the sports world as well. But I use that mindfulness and that perception of, you know, during a hard interval or something, you know, where I'm doing like mindfulness of this does not hurt, and I can calm my nervous system back down to then complete that. And it's really interesting in our domain, but just like where could our domain spread to? And I don't know, just like it's spread in the athletic world, it's huge. Yeah, absolutely.
Well, everyone, and that's the other thing too, is that one of the common threads in humanity, And it's actually where I think from a pain coping perspective, some people can struggle. Everyone has pain, except for people that literally were born and don't have pain. And they will kindly tell you they wish they did. Anyone that was born without that pain processing system will tell you that. But to be human is to have pain. I mean, we all have pain. And it's a common denominator. So to figure that out, I mean, I love that, Brittany, because I've thought about that too. I've kind of played, you know, kind of trying to, oh no. Shoot.
I think we can still hear you. At least I can. Oh, I hear you, Megan. Well, you MOT students are at least probably used to the world of technology. And I'm sure this has happened all the time. But you're all back in person, right? So that's good. Hopefully, technology goodness.
And I'm happy to see all of you guys here. Normally we have several of our students that are on field work or graduates, and I don't know where they're all at today. So feeling a little lonely from the OTA world.
Yeah, way to represent. Good work, MOT students.
Yeah, yeah.
I don't know. I mean, maybe we'll see if Megan jumps back on, but I think, I mean, we got the gist. I think some really awesome conversation where I'm going to stop recording and we can see if Megan.
So she just said everyone's frozen on her screen.